The following podcast is part of a certified educational activity titled From Roots to Results, Elevating Alopecia Areata Management. Access the entire activity and complete the post-test at peerview.com/QXZ860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Amy McMichael, Professor of Dermatology at Wake Forest University School of Medicine. Today, we're going to talk about alopecia areata, and the title of our program is From Roots to Results, Elevating Alopecia Areata Management. Our goals for today are to equip you with skills to accurately detect and assess alopecia areata. We're going to provide updates on recent efficacy and safety data and inform the use of JAK inhibitors for alopecia areata. And finally, we'll improve strategies to develop patient-centered care plans. So we'll start out with roots of the problem, understanding alopecia areata. So let's talk a little bit about alopecia areata epidemiology. Some quick facts are presented here. As you can see, the overall prevalence of alopecia areata is about 0.1 to 0.2%. It appears that male and female patients are affected similarly, although in past literature, it was stated that females had this disease more frequently. Onset typically in the first 40 years of life is common. And Asian and Black patients have higher prevalence than white counterparts. And this is really new in the epidemiology of the disease. When we talk about the spectrum of alopecia areata, there are really many ways that the disease can present. As you can see here, it can range anywhere from a very small patch of non-scarring alopecia, just anywhere on the scalp, or really anywhere on the body. We'll be focusing our thoughts today, though, on the scalp disease part of alopecia areata. And when there's loss of hair in the posterior scalp around to the posterior auricular areas, that's called ophiasis pattern. There is a particularly difficult to diagnose form of alopecia areata called the diffuse form of alopecia areata. It can be confused with telogen effluvium or female pattern hair loss. So this one may require biopsy, and we'll talk about what's required for diagnosis a little bit later. There is a patchy form of alopecia areata where instead of having just one circular area, you have multiple circular areas that sort of blend one into the other. And then just to sort of make it a little bit more fun, someone took the name ophiasis and put it backwards to say Sisypho. And that's when you have hair loss all over the scalp, except for in the posterior occipital area and posterior auricular areas. And then you can have alopecia totalis, which is when all of the hair is lost on the scalp, or alopecia universalis, when all of the hair on the body is lost, including facial hair. When we talk about alopecia areata, we really talk about it as if it's a singular disease. And it is indeed a singular disease, but there are many, many comorbidities that we can see associated with alopecia areata. Some of the most common ones are thyroid disorders such as Hashimoto's thyroiditis or Graves' disease, which are seen in quite a number of patients with alopecia areata, though most alopecia areata patients are quite healthy. We often see comorbid atopic dermatitis or atopic disease in general, asthma, allergic rhinitis, and comorbid psychiatric diseases are very common. There's a lifetime prevalence of depression and anxiety of up to 39%. And as you can see in the diagram here, we can really see any other autoimmune disease associated with alopecia areata. And just think about the stigma, when you are seeing these patients, we certainly, approach them with care and the usual feelings of compassion that we have with all of our patients. But what we don't realize is that other people in their community, other people in their lives don't necessarily look at them with that same kind of compassion and understanding. In a survey of over 2,000 lay people who were shown 3 images of the same individual with varying degrees of hair loss, there were really significant, interesting issues that came out as the image lost more and more hair. So the first image was the patient with normal eyebrows and lashes and hair. The second image removed the hair but allowed the facial hair to remain. 30% of the respondents saw those patients as being sick. When you removed the eyebrows, it became even worse. 27% perceived the individuals with hair loss as unattractive. The race and sex impacted respondents' beliefs as well. Interestingly, in the Caucasian patient, they were looked at as being more likely sick than the African American patient that was shown in these slides. So there's quite a bit of data on healthcare disparities in dermatology, and alopecia areata is really no different in that capacity. Studies have demonstrated that patients of color have lower access to dermatologic care. They have higher rates of undiagnosed disease. And there is misdiagnosis in patients with skin of color. And this is actually quite common in alopecia areata. There are several diseases, traction alopecia, central centrifugal cicatricial alopecia of the scalp, which can be misdiagnosed as alopecia areata quite readily. Black patients are less likely to be screened into clinical trials and more likely to withdraw than those of other races. And factors that contribute to this include misdiagnosis in the first place, as we talked about earlier, a low SALT score, and then a number of other medical conditions that require the patient to withdraw due to regulations for the clinical trial. The real-world study evaluating barriers to JAK inhibitor therapy for alopecia areata show that more non-white patients considered obtaining therapy, so that's good. But unfortunately, more white patients actually obtained therapy. And the common reasons why people did not go on therapy included concerns about cost and concerns about side effects. White patients were more likely to report using copay assistance card. So these are things that we need to look into when our patients come into the office. It's not just simply, well, you need a JAK inhibitor. It's, okay, how can we make sure that you actually get this medication that you actually need? Okay, let's move to diagnosing and categorizing alopecia areata. We'll take a closer look at those two modalities of alopecia areata now. So we talked a little bit about how alopecia areata can appear from the patchy to the really totalis or universalis appearance. But we can confirm the diagnosis in a number of ways if there is a concern for misdiagnosis or if there are potentially two different things going on. Typically, alopecia areata is diagnosed clinically. People come in, you look at them, it's quite clear that they have this condition. Positive pull test at the margins of active areas can also help to make the diagnosis. If you look with your dermatoscope and see that there are yellow dots in a fair skin patient, exclamation mark hairs, or black dot hairs, or if the patient's hair is red or blonde, you can see blonde or red dot hairs. And these can help confirm diagnosis. But in some cases, it's really not clear, or maybe you think there are two things going on. And in those cases, a biopsy certainly can be helpful. Typically for scalp biopsies, we do 2 4-millimeter punch biopsies, and your dermatopathologist can then help you discern if this is truly alopecia areata or not. There are several tools that we can use to evaluate and discern how much alopecia areata is affecting a patient, and these tools are primarily used to look at scalp disease. Again, there are a couple of tools to look at eyebrow and eyelash loss that we won't talk about today. The first one is the severity of alopecia tool or the SALT score. And this has been used for many years prior to us having FDA approved medications, but it really was the thing that helped us get to using medications in clinical trials because this SALT score existed. And what this score is a way to separate the scalp into 4 quadrants, the left side, the right side, each of which is 18% of the scalp, the top of the scalp, which is 40% of the scalp, and the posterior portion of the scalp, which is 24% of the scalp. And then you can use a later tool, which is sort of an addition to the original SALT score, the SALT score 2, where you can cut the quadrants into smaller squares to get a more specific amount of hair loss. And this has been a really good tool to help us understand how medications work and how people respond to medications. There's also an alopecia areata IGA or investigator analysis that helps with the assessment of disease severity by looking at the amount of scalp hair loss. Obviously, none, you don't see much hair loss at all. You don't see any hair loss at all. With limited, you see somewhere between 1 and 20%. The salt is still recommended, however, to really assess the extent, but this is sort of a rule of thumb that can be used in a clinical trial. Moderate disease is considered 21 to 49% of involvement. Severe disease is 50 to 94% of involvement. And obviously, very severe is 95 to 100% of involvement. So, really, you can use either one of these. It's quite easy to use the alopecia areata IGA in a clinical setting, maybe a little bit more easy than using severity of alopecia tool. But it's good that we have all of these tools to measure disease in patients so that we can do both clinical work and clinical trials for our patients. When we think about looking at any condition holistically, we have to look at more than just what the outward appearance shows us. So we've talked about the SALT score, we've talked about the IGA score, but when patients present to us, they're not just a score, they're not just hair loss, they're people who are experiencing a really concerning condition. And so there's now an alopecia areata severity and morbidity index, ASAMI. As you can see here, it's not just about what they have in terms of severity, although that does play a role. But what we have here is if there is limited or moderate hair loss, so someone less than 50% or someone less than 20%, then you can increase their alopecia areata severity rating by one level, or if one or more of the following is present. So if they have an episode that lasts longer than 12 months, if they have an inadequate response to 2 or more therapies, if they have a history of 3 or more relapses, and if they have signs of poor prognosis on trichoscopy exam or more busy patchy hair loss, all of these can be used to move the patient up in terms of severity. And this is something that we need to talk to our providers about. We need to talk to our agencies that help to approve the drugs for patients. Because if you have 20% of hair loss, but you have this episode that's been lasting for months and months, inadequate response to treatment, signs of poor prognosis, relapses, it's going to be very devastating to people to be told, well, you can't get this drug because you don't fit the category of severe. So I think we need to take more and more of a look at sort of this holistic assessment of patients with alopecia areata. So let's move into the regrowth revolution. How are we advancing the treatment of alopecia areata? And this is really one of the most exciting advances that we've seen in dermatology in the last 3 to 5 years. Well, typically, when we see patients with limited disease, you're most likely going to recommend topical corticosteroids, topical minoxidil, potentially maybe oral minoxidil, all of these things, of course, being used off FDA guidelines. And maybe you'll offer them topical immunotherapy or intralesional corticosteroids. And that was really the rule of thumb for pretty much everybody for many, many years before JAK inhibitors came onto the scene. When they have moderate alopecia areata, the same things are offered, but maybe we would pulse the corticosteroids with high dose corticosteroids and maybe start to consider JAK inhibitors and other systemic immunosuppressive drugs at that point. Now, when patients come in with severe alopecia areata, there's no doubt that JAK inhibitors are going to be the absolute first line. Many providers will start oral minoxidil right away, along with JAK inhibitors. That's not certainly something that was done in trials, so we don't have a lot of trial data on the combinations. But as these medications become more and more commonly used, we are seeing real world data to suggest that oral minoxidil can be helpful. We may still use intralesional corticosteroids to help with patchy areas that are not responding to systemic treatment, such as JAK inhibitors or oral minoxidil. And then second line, obviously, we may have to drop down to other systemic immunosuppressive drugs if for some reason JAK inhibitors don't work in a patient or they're not good candidates for JAK inhibitors And we need to start thinking about getting rid of some of these things that we've used for years, but really don't work and don't help our patients. So in those who are resistant to treatment, JAK inhibitors are going to be the way to go as more and more data comes out. So let's take a look at the alopecia areata pathogenesis. And so due to some amazing work by Dr. Angela Cristiano in her lab, we have found out that alopecia areata is another one of these immuno active diseases, autoimmune diseases, that works through the JAK-STAT pathway. And what actually starts the process? We certainly know that there's probably some genetic and environmental components that play a role. And once they start, the secretion of IL-15 in the follicular epithelial cells recruits and activates cytotoxic T cells. So the cytotoxic T cells that are sort of coming in because of the secretion of IL-15 start to secrete interferon gamma, which binds to its receptor on the follicular epithelial cell, leading to further secretion of IL-15. So you get this sort of cycle of inflammation occurring between the hair follicle and the white blood cell. And this cyclical action leads to inflammation and subsequent hair loss. There are many, many other sort of things going on, communication areas going on between these two cells, and we're still figuring out how they're all working. But for right now, we've got this JAK-STAT pathway that we can actually block, and that's how we get into stopping the cyclical action that leads to inflammation and subsequent hair loss. So let's take a look at the drugs that actually do this for us. Baricitinib is the first to have been FDA approved for alopecia areata treatment. There were two phase 3 studies, the BRAVE AA1 and the BRAVE AA2 study. It is an oral JAK1, JAK2 inhibitor, and it's approved to treat severe alopecia areata in adults age 18 and over. And with the study, there were two doses used, a 2 milligram dose and a 4 milligram dose. And then this was all compared to placebo. Adults with SALT scores of 50 or more were allowed into the study with a current episode of anywhere between 6 months and 10 years. And here we can see the BRAVE AA1 and AA2 data. This is looking at the entirety of a 52-week part of the study. There's even longer term data now, but you can see that starting at week 12, you started to see some improvement and some separation in the 2 milligram versus the 4 milligram dose. So if we just look at the baricitinib 2 milligram dose, which is the blue line on the BRAVE AA1 and the BRAVE AA2 study, we can see that by 36 weeks, we were really getting significant improvement. We don't have our placebo on this scale right now, but you can see that there's significant improvement. But the 4 milligram does work better, and both trials did bear this out. So nearly 40% of the adults taking 4 milligrams of baricitinib saw at least 80% scalp hair coverage at 52 weeks in this pivotal trial, or in these two pivotal trials. So this is really important data. So both 2 milligram and 4 milligram work. The package insert suggests starting at 2 milligrams, but a lot of patients are starting at 4. And there is some ability for providers to really think about what their patients need. And so what we're getting is patients improving with a medication that was previously used for other things. And so one of the lessons that we've learned is that responders tended to have a little lower duration of their episodes. So the 69 to 77% of responders had baseline duration of less than 4 years. So the longer that you have the disease, the harder it is to treat. So the earlier the treatment, you're going to have better outcome. And, just on the sort of opposite side of that, those who had greater than 4 years tended to be more likely non-responders. So this is important. We need to get patients on these medications earlier to make sure that we can actually give them the best outcome. When we look at rates of response, The baseline SALT score of 50 to 94 was associated with early response, and those who had a higher SALT score, in other words, less hair, were associated with a late response. So it took a lot longer for patients who had close to totalis to respond. And so that's really important again, too. When you start patients out on these medications, you're not necessarily going to be seeing a response early on. Perhaps you'll see a response later on. So we have to give them time to work. This is not something that you go on for 2 or 3 months and say, oh, it's not working. You really have to give them time to work. So let's look at the safety of baricitinib at 52 weeks. As you can see here, the common side effects or adverse events were upper respiratory tract infections, headaches, nasopharyngitis, and those are things that you typically see in most trials, that sort of thing. But they did see acne, and we know with JAK inhibitors that you can see a little bit of increase in acne, particularly in our younger patients. You can see CPK elevation. And with all of these drugs, with CPK elevation, we understand that we really don't know what it means, but it has no bearing on patient health. And that has been borne out in every single one of these trials. It doesn't impact their muscle health. It doesn't impact their response to treatment. And it just isn't something that we're worrying about right now or even measuring. COVID infection was happening during these trials just simply because of the timing of the trials. And so you're going to see that across the board in these trials. Elevations in LDL and HDL were observed, and that sort of leads us to monitor these things. But what we don't see is a whole lot of malignancy, serious infection. What we do see is a little bit of increase in herpes zoster. So in some of the trials that we'll talk about today, patients were actually treated with vaccinations prior to being in the trial, and we're not seeing death. So that is very, very good for our patients with alopecia areata who are basically healthy to begin with. We're not increasing their risk for severe disease. Ritlecitinib was the second FDA-approved drug for alopecia areata, and they looked at this drug in the ALLEGRO trial, which was an interesting trial because it wasn't the typical 2 phase 3 studies. It was actually a phase 2b, 3a trial. It's an oral JAK3 TEC inhibitor, and it was FDA approved to treat severe alopecia areata in patients aged 12 years and up. So different from baricitinib, you can actually treat adolescents with this medication. So in this trial, patients greater than or equal to 12 years of age with a SALT score of greater than equal to 50 and a current episode of 6 months to 10 years were put into the trial, and several different doses of medications were used. Ritlecitinib 50 was what was ultimately decided upon as the approval dose, but there are many other combinations of doses in the 2b, 3a trial. And of course, all of this was compared to placebo. So in this graph, you can see the proportion of patients with SALT score less than 20. And you can look at the week 24 data, which shows ritlecitinib 200 tapering down to 50, as well as the ritlecitinib 50 milligram doing the best of both of all the different dosing regimens that you can see here. And then taking the trial out to 48 weeks, you can see that they still maintain that efficacy. When we talk about the safety of ritlecitinib, it's very similar to baricitinib. The most common adverse events were headaches, nasopharyngitis, upper respiratory tract infections, which is very similar to what we recently said about baricitinib. Again, that acne, zoster, I'll point this out again, is increased here in these patients. And so again, for patients who are at risk, going ahead and doing vaccinations prior to starting the medication makes a lot of sense. And also talking to patients about this prior to starting is important. There were malignancies, but again, nothing that we can say is outside the norm of what is happening in the background of those who are on placebo. No significant MACE events, thromboembolic events, very, very little, and no deaths. So again, we're looking at a side effect profile that really is looking very, very clean for our patients with alopecia areata. So the final approved drug, the most recently approved, is ruxolitinib. They actually did the Thrive AA1 phase 3 trial. This is an oral JAK1, JAK2, and TYK2 inhibitor, and it's FDA approved to treat severe alopecia areata in adults only. So with this one, adults with alopecia areata, so 18 and over, with a SALT score greater than 50 or equal to 50, were entered into the trial, and they had to have a current episode duration of 6 months to 10 years. So very much similar to the other trial requirements. In this trial, ruxolitinib 8 milligrams and 12 milligrams were used to compare to placebo. And as you can see here, both of the doses worked quite well compared to placebo. And you can see this is really just out to 24 weeks. We don't have the later data presented here, but both did very well. And what's interesting is that in this drug trial, the separation from placebo started working very, very early. So around week 8, you started to see separation from placebo in those patients taking the drug. With actually approval, though, the 8 milligram twice a day dosing is what's going to be FDA approved, or what is FDA approved. The 12 milligram dose is not going to be used, at least at this time. So when we look at safety of ruxolitinib, it really compares very similarly to the other two JAK inhibitors that we've talked about. You see the typical common things with upper respiratory tract infections, but not serious ones. We see acne again, the increased CPK that we don't worry about, but really no MACE events, no deaths, no malignancies. And in the 24-week trial, we certainly didn't see any vascular thrombotic events. And interesting, less herpes zoster in this trial compared to the other ones. It doesn't mean that it can't happen, however. So in the JAK inhibitor class, we always want to talk to patients about that. Let's talk about balancing risks and remedies. So there is, unfortunately, a JAK inhibitor boxed warning. It talks about the fact that patients who take these medications can have serious infections, that there may be an increased risk of all-cause mortality, that they may be at risk for both solid tumor and blood malignancies, that there may be more episodes of MACE, and certainly maybe an increased thrombosis risk. So where did all this come from? Well, all of this came from safety signals seen in rheumatoid arthritis patients with subgroup analysis of oral surveillance studies in patients who had taken tofacitinib. So one drug and in a diagnosis that is not alopecia areata. This is a typically much older group of patients, a group of patients that have been taking very high dose steroid as well as high dose immunosuppressive agents for many, many years, and using it to make really big decisions about a different set of drugs in a different group of patients. So we really are beholden to, unfortunately, this subgroup analysis of this surveillance study. In that study, there was increased MACE and increased malignancy, as well as increased thrombosis in patients who are over 65 years and over 50 years. So for this reason, we do need to at least talk to our patients about what's in the box warning, because if they get a drug and they don't understand it, it might be a reason for them or an excuse for them to stop. Fortunately, safety signals were not replicated in subsequent large real-world evaluations, and there are several studies now that do not show these same issues. However, the box warning stands, and we need to make sure our patients are educated and understand why it's there, and also understand that we are monitoring them appropriately to make sure that nothing happens to them while they are at very low risk of any of these things happening, at least in patients less than 65. So we've talked about the safety of individual agents. In a meta-analysis of 36 studies, we see that the most common adverse events overall are headache and acne. The most serious are not really seen and they were not increased over placebo in this meta-analysis studies of all of these JAK inhibitors in alopecia areata. So there are some proactive strategies that we can use to assess patient candidacy for JAK inhibition. When you're talking about potential cardiovascular risk, smoking history, and other risk factors such as obesity, history of MI, history of stroke, those are going to be things that you want to ask your patient about and make sure that they don't have those. They should not have a risk of clotting or malignancy other than skin malignancy. But you really do need to ask these questions before you just throw someone on a medication anyway. Certainly, if they have underlying infections, we don't want them to start a JAK inhibitor. We do usually recommend hepatitis testing and quantiferin gold testing to make sure patients don't have hepatitis or TB before they start JAK inhibition. In terms of the disease process itself, when it comes to real life, most of us are not going to be worried about duration of the episode, even though we know data from the studies tells us about this. Certainly, if someone has been non-responsive to other treatments, we're going to try this drug anyway. But we do want to know about treatment history, severity, episode qualities, and that sort of thing. And some of those are going to help us get to using the drug. So are they having all of this worsening and non-response? It's going to be a way for us to get more patients on the drug as opposed to less patients on the drug. So what we do need when we're monitoring patients is baseline CBC with differential. And then during therapy, you can certainly do this at 4 weeks and then periodically, maybe about 3 times a year is what I tell my patients. We like to look at renal function, make sure it's normal at baseline, and then repeated, perhaps about 3 times a year as well. Same for liver function tests. Not that we see a lot of abnormalities in the studies, but this is just sort of routine to make sure that their overall health is not changing, and that might make you think about changing their therapy. We do know that lipids can be elevated in the trials with JAK inhibitors, so we do monitor those at baseline, and then again at 12 weeks and periodically throughout the year. Usually, again, I do this about 2 to 3 times a year for patients. Infections, I again like to get hepatitis labs as well as quantiferin gold labs at baseline, and then in accordance with clinical guidelines after that. If patients have abdominal symptoms prior to initiation, uh, it's best to have this looked into. Maybe have a gastrointestinal specialist evaluate them prior to initiating the drug if they have symptoms. And certainly, if any arise during therapy, you would send them to the appropriate person to have this evaluated. Skin exams are important to do throughout the patient's course. If they notice anything new or are coming up, you're going to evaluate this when they come in for evaluation. At this time, we are not treating pregnant patients at any point with JAK inhibition. Make sure that your patients are not pregnant when starting the drug and that they don't become pregnant while on therapy. And interestingly, only ruxolitinib has this monitoring of CYP2C9 genotyping. So as you can see, not much to do, and it's certainly not very complicated, doing baseline labs and then a few times a year. And this is something that patients really can get their heads around if you present it that way. From diagnosis to support, let's talk a little bit about building a cohesive care network for your patients with alopecia areata. When we look at patient preferences, over 1,000 individuals with AA completed a survey about what they wanted in terms of their own treatment. A whopping majority of patients consider ability to achieve hair growth as the most important thing, and that's no surprise. They really all value information about treatment as important, and they rank side effects as important as well. They also, at 75%, view cost as important. So there's no sense in having a medication and you can't really afford to get it. So this is important information to sort of internalize and take with you as you treat your patients. And when you're talking about different treatment options with your patients, Some of the things that you want to discuss with them in order to have a real experience of shared decision making is, what are their ultimate goals? What are their preferences? Are they people who can take an oral medication? Some people can't swallow a pill. It's not going to be for them. What is the risk for their particular state of health? How are they going to pay for this? Do they have insurance coverage? Is there going to be a way to get this that will not be problematic for their family finances? Are there barriers to care, transportation, adherence, again, cost and coverage? And what are the cultural considerations that you have to give to these patients? Is there intersection of care goals and cultural preferences? So these are all things that should come out in your conversation with patient, really with any treatment for alopecia areata, but particularly so for JAK inhibition. And then we'll come to sort of our final idea of how we optimize patient counseling. Really, it comes down to educating the patients on what they have as a disease process. We want them to understand that this is an autoimmune disease, not something caused by stress. We know that it's caused by genetic and immuno function in the cells where immune privilege is lost. We want them to understand the treatments, and we want them to understand which treatments are going to give them potential side effects, potential pain, potential long-term costs, and also what resources are available to them in terms of educating them, such as the National Alopecia Areata Foundation or other resources, and also what are the resources for coverage of medications. We can talk about the expected benefits. Growth of hair is a big benefit for these patients, obviously. And what we have to be clear about, though, is the likelihood and the anticipated timeline for hair regrowth. While we all would love to have hair regrowth very quickly, sometimes it takes a while. And so we have to be able to help patients understand that 9 to 12 months is not too long to wait to see hair growth on the newer drugs that we're able to give them now. We want them to understand the expected tolerability and safety of the medications that we're offering them. We want them to understand the most common adverse events and how we're going to monitor these adverse events for the patients. Cost, coverage, and access is a huge issue for a lot of patients. And we want to be able to talk with our patients openly and honestly about how we can get them medications, but also prevent them from having to stop if their insurance coverage changes or if there is some change in insurance ability to copay. And what are the medical assistant options that we can offer these patients? And finally, we're not treating these patients in a vacuum. There needs to be interdisciplinary care. We need our pharmacists to help us with prior authorization and education. We need our specialty pharmacies to help us get the medications to our patients. We need our other GI, potentially rheumatologic folks to help us in guiding patients if they have other autoimmune diseases. And really, there has to be a good flow of communication and collaboration in helping these patients get to the goals that we all want, which is hair regrowth and management of their alopecia areata in a very healthy and appropriate manner. So thank you all for listening to our talk today. We hope you've learned from this educational experience and can benefit your patients by using the knowledge that you obtained.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Pfizer. To access all materials for this activity, visit peerview.com/QXZ860.